Let's jump in with talking about oxygen. It's on the health leaders and presidents around the world. Ali Velez.
Thank you very much, Tom and team, for this invitation. For the ones that doesn't know me, I am Alejandra Velez. I am a biomedical engineer, and since June last year, the technical focal point for this oxygen scale-up initiative in WHO. So I would like to share with you what we have done and where are we and where we would like to be still and celebrate for the biomedical engineering work done through the oxygen and biomedical access in the countries during this pandemic. So we have this website that some of you already know, where we have been trying to integrate some guidelines that we have developed among all the multidisciplinary teams in WHO regarding the medical devices, the clinical guidance for treatment and innovations. As you know, for example, the Compendium of Innovation that was launched yesterday. We have also trying to connect with other tools and information available from other partners that are working in the space. And we have been trying to build also information regarding to the oxygen sources at the scales that we know before there were not a lot of information related to the PSA plants and the oxygen and the liquid oxygen production. We also want to build more in the webinars and training sessions that we have been doing with the regions and countries. As you may know, WHO works serving member states and around the world. We have 5 regions, and we have been doing webinars together with the countries along them. So here we have been trying to put information, as every platform needs more update and more work on it, but you can access, and you will find one of the main products that we have is the WHO Technical Consultation Reports. That was one of the achievements we have during at the end of last year. And it's a good reading to understand all what is around the oxygen ecosystem, the challenges, the existing information and existing capacity that we could already start mapping, and alternatives that we have to cope the emergency. The next one, please. But even though we have been working already during 1 year regarding the oxygen scale-up, we still are asking ourselves how many health interventions will improve the outcome if the oxygen is there for oxygen therapy. What will be the costing of the treatment per intervention, how to do the forecasting of oxygen needs and needs gap assessment per national and subnational level, how to increase the equal distribution and access, not only for oxygen, but for all the medical devices related to the oxygen therapy, how to ensure international standards are applicable everywhere. We know this is one of our main concerns. If we want to ensure quality, and the international standards are mainly done for high-income countries, how can we bridge the gap between this and the procurement we are doing for the countries that we mainly support? Also, how to bridge the gap between the technical guidance and the implementation. There is a lot of work that it has been done in the Department of Medical Devices under the lead of Adriana Velázquez. And it's great work, but sometimes when we want to apply it into the country and with the biomedical engineer and technician working in the hospital, we find that it's difficult for them to get access to the tools or to the recommendations that are there because there is lack of policy or lack of local guidance to implement. And then the question is, are there enough guidance already for low and middle income countries, or we can still working on that? Next one, please. But besides that, one of the things that we already know and we better know is that we need biomedical engineers along all the life cycle of the medical devices. I think this has been one of the big achievements that we have heard during this year. Dr. Tedros, the Director General of WHO, speaking about the needs of all different kind of medical staff, including the engineers, and how important they have been for the maintenance, for the procurement, and for the management of medical devices like the patient ventilators and the oxygen sources that were not before very on the spotlight of the emergency procurement. We need to have workplaces. We know we need to have workplaces, workshops for the biomedical engineers everywhere. And I can share that in the field visits I have done, like this one in Afghanistan or in another country in Africa, there are still not enough places, enough tools, enough software to manage the equipment and to do proper maintenance. We know that the biomedical engineer needs to be along also all the areas of work like innovation, availability, appropriateness, working with the policy makers, working with the markets, working with the cost effectiveness studies, etc. Next one, please. I want to share that sometimes the problem looks so big, and in the case of oxygen, it looks so big when I started last year, and we didn't know how to start working on it because there is no, as we know, a lot of existing baseline data, and we were like, okay, how do we do it? And the way we have been trying to do it is in a stepwise approach, trying to have also already the holistic view of the things, but trying to see everything at health facility level, then at subnational level, and then at national level. Trying to select what will be the solution, bundle the solution, cost the solution, and then unbundle to be able to start with 1 or 2 or 3 options of the solutions and not trying to cover the whole, because we know as biomedical engineers that this can be, here I just put like the main components of a system, but we know it can go up to the shipping, up to the innovation part, or all the upstream of the supply chain, and it's a lot to tackle and to work in. So this is how we have been doing as an holistic entire approach. Next one, please. Also, every time we visit a health facility, I have been sharing this with all our colleagues for the multidisciplinarity, that what do we see as biomedical engineers? We also see an holistic assessment, and it's similar to what happened to the doctor, that they cannot see only one illness when they are treating a patient. They see the patient. They know the patient can come with different allergies, with different genetics, with different comorbidities. So it's the same. When, as biomedical engineers, what we do when we assess a health facility is we check the infrastructure, we check for the management of the equipment, how the donations has been received, what is the maintenance programs that they have. Unfortunately, we find a lot of these cemeteries of equipment. Then we look for the workforce and the workshop, how they feel also in terms of how they are paid, how they are trained, if they had access to a university or to a technical and formal education or not. Who is managing the contract with suppliers, if there are enough local suppliers, or they are coming from abroad, or is it just related to one big supplier saying that they have expertise in everything, etc. We also look for the value chain and cost of all the supplies. In this case, it's related to the oxygen. What is the comparison between using liquid oxygen or PSA plants, etc. We also see for the rational use of the oxygen in this case, and all the devices related to the oxygen therapy and pulse oximetry. And we need to see what is the context. In this case, for example, as the energy is one of our main constraints in some of the countries we work, we need to see, for example, the market of the fuel and the power generation in the countries. So it's the only way to assess and come with contextualized solution to see the holistic context and the holistic approach. Next one, please. And we also—
Ali, I need you to wrap because we got to keep going. And I'm going to cover some of this also, but realizing I'm speaking to the WHO expert about oxygen. I mean, I say that humbly because we thank you for the incredible work you've done, but I'd like to move on if I can.
Yes, and so in general, what we can see is that the issues are similar everywhere. We know the lack of maintenance, lack of biomedical engineers, lack of spare parts, etc. But just being able to do a holistic assessment, we can find a different and contextualized solution for each of the countries. Next one, please. And so this is the conclusion of today for me, is what would we need to adjust from clinical engineer. We need, here I put some ideas of the areas of work that I have seen. In terms of education, I have seen that even we got some funds for biomedical engineers at country and regional level, we don't find a lot of biomedical engineers because still there needs to be a lot of university programs, a lot of tools, online tools that now can be available, and programs that can reach really all the context and all the people that wants to be trained and wants to receive information. We need to do more appropriate innovations. Not only, I'm not saying that fancy technology is not needed, but we need to do sustainable solutions and appropriate for each of the context environments that they will receive the technologies. We need to work also as biomedical engineers in developing policy guidelines and sustainable and trustable platforms for sharing information, because there is a lot of, and we saw it during that last year, a lot of information that was bad about the innovative ventilators and things that we couldn't really see if they were applicable or standardized or quality, of good quality. And we need to still involve the biomedical engineers along all the process, from the decision making and up to the decommissioning of the medical devices, because still there is a lot of perception that the biomedicals are only for the maintenance or for the technical support, but they don't consider how the biomedical engineer can be implied in the decision making process of the appropriate technologies. That's all. Thank you.
All right. Thank you, Ali.